All right, so we're going to talk about the entire pharynx as such, and everything that's important about the pharynx. We're going to speak about. So first, while the first thing that you think about when you're talking about the pharynx is the entry of the pharynx. So we know that there are three parts of the pharynx. There is a nasopharynx, there's an oropharynx, there's a laryngopharynx. So now, if there is to enter the pharynx, the best option is go via the oral cavity. So we've got the tongue, and that's where the discussion begins with the tongue, and tongue develops from the bronchial mesoderm. All right. So well, if you think about the bronchial arcs and cleft and the pouches, the thing is that when you look at this particular diagram, uh, we've got the arches, that are the bronchial arches, and I'll shade the arch in red. Let's shade the arch in red. So this is the arch, and that's having mesoderm. All right, so that's the mesoderm. We've got the pouches, so these are the pouches. So let's shade the pouches in green. These are the pouches: pouch 1, pouch 2, pouch 2, pouch 2. And we've got the clefts, so in blue the clefts, or in yellow the clefts. So cleft 1, cleft 2, cleft 3, cleft, or whatever. So we've got the development of the tongue that occurs from the distal tongue birds. These are the distal tongue birds that are also seen in this picture. So let's use this distal tongue bird. We've got the median tongue bird, then we've got the foramen cecum of the tongue, and then we've got the hyperbronchial eminence. So when you think about it, the hyperbronchial eminence is from third and fourth arch, right? So it's from the third and fourth arch. So effectively the tongue develops from the first arch, obviously. So tongue develops from the first uh, arch, all right, from the third and the fourth arch. All right, now the third arch is the nerve glossopharyngeal, the fourth arch has the nerve called as vagus, and the first arch has the nerve called as mandible, uh, mandibular nerve, right? So therefore, when you think about it, when you look at the tongue, okay, we'll look at the tongue later. I just need to talk about the important derivatives of each arch. So the first arch has its derivative as mandibular and maxillary nerve, all right, and also the chorda tympani, and the muscles of the masseters, temporalis, malloid, all of those that help in chewing movement of the mandible. And the bones are going to be malleus incus, and the sphenomandibular ligament. All right. Second nerve is the facial nerve. Third is the glossopharyngeal, that you need to remember. Glossopharyngeal has only one muscle, that's the stylopharyngeus, and it is from the greater corner of hyoid and the lower part of hyoid. Okay, that's not that important. About the facial nerve, because the second arch is not involved in the tongue, I do not really think that we should focus too much on it. But if you want to, stapes is one that you should remember. Stylohyoid ligament is one, and the muscles are going to be all of the face, the facial muscles as well, and platysma, and very important is the posterior belly of digastae, whereas the anterior belly of digastae is actually supplied by the nerves from the first arch. Now talking about the fourth one, we've got the superior laryngeal nerve, and sixth is the recurrent laryngeal nerve. Important to remember is that recurrent laryngeal nerve is all the muscles of the larynx, but the cricothyroid is from the superior laryngeal nerve, and fourth arch gives the laryngeal thyroid and epiglottic cartilages. Now looking at the tongue, this is the sulcus terminale, and here you've got the foramen cecum, the foramen cecum. All right, this is the sulcus terminale. You've got circumvallate papillae out here. That's important. So this is the posterior one-third of the tongue, and then you have the anterior two-third of the tongue. Anterior two-third comes from the first arch. The posterior comes from the third arch, and the posterior most part comes from the fourth arch. So similarly, the nerve supply is going to be, here you have a lingual nerve and chorda tympani for taste. Here you would have your glossopharyngeal nerve for taste and sensation both, and the fourth arch you would have your vagus nerve for taste and sensation both. So after we've spoken about the tongue, you should know that the referred pain is, because the lingual nerve is the first arch, the referred pain is going to go to the very important auriculotemporal branch of the mandibular nerve, and therefore you're going to have pain in the ear, because The lingual nerve is also part of the mandibular nerve, and auriculotemporal is also part of the mandibular nerve. uh, if there is in the posterior fourth arch, let's say there's a carcinoma or anything, so you would have pain at the Jacobson nerve. Jacobson nerve is basically the nerve at of the middle ear, so you'll have pain there. And then the posterior most you would have at the fourth arch, which is the vagus nerve or the Arnold's nerve, and again it'll be at the ear only. Arnold actually supplies the external auditory canal as well. Very important to know is that if there is the muscles of the tongue are supplied by the glossopharyngeal, by the hypoglossal nerve. So the hypoglossal nerve palsy is going to lead. So let's say if there's a palsy on this side, that is the left, all right, and this is the right. So if there's a palsy on the left, let's say the okay, so the tongue is going to deviate to the obviously the tongue is going to deviate to the weaker side, all right. So if left is paralyzed, all right, if left is paralyzed, that means the muscles of the left are weakened, and the tongue will move towards the right, all right. So towards the weak side, that is the left side. That's where the deviation of the tongue would be. Now coming to the pharynx, we have nasopharynx, oropharynx, laryngopharynx. I told about that. The nasopharynx is basically from the base of the skull to the hard palate. So it is at the C1 vertebrae, and it's made up of ciliated columnar epithelium. The oropharynx and the laryngopharynx or the hypopharynx is stratified squamous epithelium. Oropharynx is from hard palate to the cricoid and to the hyoid, and laryngopharynx is from the hyoid to the cricoid. Now, the vertebrae that they correspond is important because hyoid to cricoid is C3 to C6. The oropharyngeal is C2 to C3, and both of them, as I told you, stratified squamous non-keratinized epithelium. Coming to a very important thing, term called as Waldeyer's ring. Waldeyer's ring is something interesting. Waldeyer's ring is lymphoid ring. So, Waldeyer's ring is composed of adenoids, tubal tonsils, starting superiorly. So it's actually not a ring, it's a oblique ring, if I want to talk about it. It's not a proper ring, but superiorly you have the adenoids, then you have the tubal tonsils. Go inferiorly, you will have the lingual tonsil, and posteriorly you would have the palatal tonsils or the facial tonsils. Now talking about that, tonsils, the palatine tonsils and the lingual tonsils are in the oropharynx as it's indicated in yellow OP, and the adenoids and the tubal tonsils is in the nasopharynx as it's indicated in the NP nasopharynx. Now this is basically the internal Waldeyer rings, and there's also something called as external Waldeyer ring, which is when the adenoids, they drain directly into the retropharyngeal lymph nodes, that is RP indicated in the diagram, which is level 5 of lymph nodes. The eustachian tube and the tonsils, palatine tonsils, drain into the jugular digastric, which is level 3, and the lingual and the tonsils, palatine, drain into the submandibular, which is level 1, submandibular and submental. Coming to the muscles of the pharynx, the muscles of the pharynx are 3 and 3, okay, so 3 plus 3, so 3 paired, not 3 paired, so we'd say 3 longitudinal, 3 circular. Longitudinal are the salpingo, stylo, and palato. Salpinx basically eustachian tube, so it arises from the eustachian tube to the of the nasopharynx. Stylo is from the styloid process, and palato is from the palate, that's of the oropharynx, and they go and attach directly on the thyroid as a single aponeurosis. And what they do is they all are dilators of the pharynx. All of them have nerve supply by the vagus of the pharyngeal plexus, except the stylopharyngeus, which is glossopharyngeal nerve. And important are that these dilators, these longitudinal muscles, they are complete, they are inner, and the circular ones are the outer ones. So it is really important to understand the constrictor muscles. The constrictor muscles are superior, medial, and inferior constrictor, not very complicated. Well, all of them insert into a midline raphe, and because they insert into a midline raphe posteriorly, they do overlap a lot. They overlap posteriorly, and As they overlap posteriorly, they are deficient laterally. So laterally there are a lot of deficient spaces, and a very important thing is that all of these the insertions and origin of each of these muscles, right, uh, is from the midline fibrous raphe. They attach at the midline fibrous raphe, and these muscles also give space to certain structures to allow them to pass. So, for instance, superior constrictor actually comes from the from the pterygoid and the pterygomandibular raphe, and pharyngobasilar fascia. All right, so it goes and it attaches on the posterior part of the midline raphe. But when it does that, there is a certain gap which is called a sinus of Morgagni, and sinus of Morgagni is a space that allows these structures TALLA thala to pass. Now thala is basically, T is tensor palatini, A is auditory tube, okay, L is levator palatini, A is ascending palatine artery, and A is ascending pharyngeal artery, palatine branch. All right, so like I know it's shady, it's very shabby, but I think shabby is the way to learn. Okay, so obviously thala is the one. Now here between the superior and the middle, we have a very important structure that's passing. That's the glossopharyngeal nerve. We've got the glossopharyngeal nerve that's passing, and inferiorly we have the vagus nerve that is passing between the inferior and the between the middle and the inferior. We have the vagus, and between the inferior and the esophagus we have the recurrent laryngeal. So out here we have a recurrent laryngeal, as you can see, inferior and the esophagus. Between the inferior constrictor and the middle we have the superior laryngeal, or the internal laryngeal, if you want to say it. Obviously the external laryngeal is not going to enter there. Once that is done, I wanted to talk about the inferior constrictors. The middle constrictors is not much important. The inferior constrictor is important simply because it has two parts: the pharyngeus and cricopharyngeus. Thyropharyngeus is like this, cricopharyngeus is like this, and there's a space called Killian's dehiscence. And from there's a Zenker's diverticulum, and this Zenker's diverticulum is arising because of neuromuscular incoordination, where the thyropharyngeus contract and cricopharyngeus fail to relax, something like that. All right, so it's a false diverticulum, and it's on the left side, okay, and there is gurgling sound which is called as a voice sign, all right, on palpitation. Also you have halitosis, you have dysphagia, you have laryngitis, you have upper respiratory tract infection, and you have a cough, you have pneumonia. So you have all of these symptoms that are coming. How do you want to diagnose it? You want to do a barium swallow or an endoscopy. As I told you, it's a false diverticulum, and the cause is neuromuscular incoordination. Treatment: how do you want to treat it? Obviously you want to treat it by two. You want to first of all you want to do laser technique. All right, laser, and laser is or you could do balloon dilation, or you could do endoscopic stapling. All right, you could do that as well. Now what is endoscopic stapling? Endoscopic stapling is recommended. What happens is that, let's say if this is the pharyngeal pouch, what you do is you cut this. All right, you cut the walls, and I think instead of this being like this, what you do is that you make it like this, so that all the pooling does not occur. If it just directly enters into the hypopharynx, as it should, of even food content, usually, obviously. So staple the wall. So that's called endoscopic stapling, and you have laser as well. Laser is going to reduce the Zenker's diverticulum. Talking about fascia and spaces, we've got important fascias. All right, we've got important fascias that I wanted to talk about. We've got the pharyngobasilar, we've got the alar fascia, and we've got the prevertebral. Pharyngobasilar is in contact with the muscle. Between the pharyngobasilar and the alar, we have the space of Gillette, or retropharyngeal space, which has a fibrous raphe, and it also has something called as nodes of Ruvy's. Now this nodes of Ruvy's is important, all right, because abscesses may be formed, and because of this fibrous raphe, there's usually a unilateral raphe, not a midline raphe, midline abscess, sorry, a unilateral. All right, and then we have alar fascia and prevertebral fascia. We've got a space called the deep we've got the dangerous space, not the deep, sorry, the dangerous space. And the dangerous space is called between alar fascia and the prevertebral, and between the prevertebral and the vertebrates we have a prevertebral space. That's very basic and common. All right, the extent, most of all of these extend to T4 except the dangerous space, and the dangerous space goes all the way to the diaphragm. And the reason why it's called dangerous is because it can lead to infections of the diaphragm, and that's why D for diaphragm, D for dangerous space. That's it. Let's say retropharyngeal bulge. If you have a unilateral bulge, obviously it's a retropharyngeal abscess, obviously, that I've spoken about, because there's a fibrous raphe. So in child it could be because of lymphadenitis, all right, because of the nodes of rubies, or if it's adult it could be a fishbone, all right. But in chronic abscess it could be a TB, all right. But if it's midline, so it is obviously a posterior prevertebral abscess, and it is seen in TB of the spine. And that is about it. When we say, obviously, if you want to diagnose it, you want to do x-ray, and on x-ray you want to see normal vertebral shadow. But to differentiate between these two, you want to do a CT scan. All right, you want to do a differential. If you want to differentiate between a retropharyngeal and a prevertebral, you want to do a CT scan, simply because X-ray cannot differentiate. However, you will obviously see a shadow. You will see you will see loss of the normal prevertebral shadow. You will see straightening of the spine. Okay, in X-ray, what will you see is you will see straight spine. All right, plus you will see increased shadow. So the normal shadow is gone, and you'll have like increase in prevertebral shadow. But obviously you want to do a CT now. X-rays are obsolete. Now talking about retropharyngeal abscesses, continuing on that, we have obviously the one that is, I told you about. Obviously in adults it can be due to a fishbone, and it could also be due to chronic TB. Does not necessarily mean that TB is associated with prevertebral abscesses directly. Obviously, how do you want to treat it? You want to treat it by drain and IV antibodies, or if it's IV antibiotics, sorry, and you could use ATT for chronic. All right, so you cannot drain a TB abscess. Never drain a TB abscess. All right, what does the patient complain? The patient is going to complain the simple and the most basic stuff. He's going to have fever, he's going to have dysphagia, he's going to have fever, he's going to have dysphagia, vibrio fever. Lymphadenitis could be because of any bacterial caused fever. Dysphagia or odynophagia because of the pain while swallowing. Obviously it's an abscess, obviously. And he would also have torticollis. He could have because of spinal muscle stiffening as a part of inflammation. So torticollis does not necessarily mean that there has to be damage to the spinal accessory nerve. It could be due to inflammation as well. Coming to the other one, spaces. The other spaces are parapharyngeal space, which is an inverted triangle. Now talking about that, it's basically between. It's an inverted triangle between the mandible and the lateral pharyngeal wall. If you want, we could write it down as lateral pharyngobasilar fascia, but obviously all the fascias do come together out there laterally. So why is this important? So it's important because it's a part which is divided by the styloid into prestyloid and poststyloid. Okay, so when it's divided into, so I want you to imagine that there is a space. Okay, there is a mandible. Okay, there's the mandible. Okay, and then you've got the pharynx around here somewhere. Okay, and you've got all the muscles around. All right, you've got the muscles around as well. So I want you to imagine this simple. Okay, and you've got a styloid out here. You've got your medial pterygoid plate. Obviously, you know the medial pterygoid will have the pterygoid muscles attached. But let's not write about that. It's a waste of time. So let's just write mandible. Mandible is out here. The mandible is out here. Wow. So the way the biology is designed is too good. So the mandible is out here. You've got the styloid. So the styloid is converting this into a posterior and the anterior space. All right. Now the posterior, if you think about it, all right, and here you have the vertebrae. So I'm just talking about this particular space. Okay. Let me just shade it up with white. I'm talking about this space. Okay, now in this space, if you talk about it, it is somewhat an inverted pyramid where it goes down. Okay, and the styloid is going to have its three pairs of muscles, obviously the stylohyoid, stylothyroid, stylopharyngeus. Okay, and so I'll write 3 out here. I'll write a 3 out here, so that there are 3 muscles that you know of. Okay, there are 3 muscles out here. Okay, so in the posterior space, what do we have in the posterior space, or rather what do you have in the anterior space? In the anterior space, well, in the anterior space you have fat. Obviously you have the muscles of mastication. That's very important. All right, so you have the muscles of mastication in the anterior space. You also have a very important nerve. You have a mandibular nerve, so you have the mandibular nerve. All right, and in the posterior space you have all the important cranial nerves like the 9th, 10th, 11th, and even the 12th cranial nerve. Okay, and you have the internal carotid artery, you have the internal jugular vein. Wow, so this is how important the posterior space. And they also have the cervical sympathetic ganglion. All right, so now think about it. Okay, if I want to make the boundaries, first laterally is going to be your mandible and the muscles. What are the muscles? Medial pterygoid. Okay, masseter. Okay, parotid. Okay, parotid is going to be more posteriorly. If you want to know, parotid is going to be somewhere out here, but fair enough, you could add parotid. Okay, so medial is going to be lateral wall of the muscle, lateral wall of the pharynx, and which is the first fascia? That's the buccopharyngeal fascia. Obviously that's a no-brainer. Okay, so the buccopharyngeal fascia. Now what's going to be lower? Lower is going to be hyoid, because the buccopharyngeal fascia is up to the hyoid. We know about that. All right, it's up to T4. Okay, and usually we want to keep it to hyoid. Okay, and the upper is going to be base of skull. Now a very important point that we need to know is that the complication of anaphyses in any of these spaces, probably in the anterior space, if you want to talk about the complications in the anterior space, or you want to talk about the complications in the posterior space. So if it's in the anterior space, you have to think about it. Obviously you're going to have muscles of the mandible involved, so you're going to have a lockjaw. And you're going to have trismus. Trismus is basically lockjaw. If the posterior compartment is involved, let's say your cervical sympathetic ganglion is involved, so you'll have torticollis. Also you'll have direct inflammation of the spinal muscles, and you're going to have Horner syndrome. And torticollis is actually going to be because of the 11th cranial nerve, which is the accessory nerve. All right, and that supplies the trapezius and all the muscle and the muscles of the neck. So because of trapezius, you're going to have torticollis as well. You're going to have trapezius, and you're going to have sternocleidomastoid. So sternocleidomastoid involvement is actually going to cause torticollis, not trapezius, but sternocleidomastoid. All right, that's important. That's basic anatomy. It also supplies trapezius. That's my point. All right, and abscess in the anterior space, what can it cause? Well, if you know, this is at the level of the oropharynx, obviously. So therefore there's going to be also very important structure which is called as a palatine tonsil. So the palatine tonsil can be pushed medially, and the palatine tonsil is pushed medially. So so that's why you need to worry about that. Okay, and in an anterior you are obviously going to see a very large abscess at the angle of the jaw. Okay, so that's very important. While giving an incision at the angle of the mandible, a very important nerve runs, which is the facial nerve, which is the facial nerve, but the marginal mandibular branch of the facial nerve, and that can if that is damaged, obviously your lagging lip will occur. So your lip, okay, so look at the lip that I'm drawing. Obviously it's shabby. My work is to be shabby. All right, so if this is the lip, okay, the lip is going to lag if the damage is on this side. All right, this is my lip. What a beautiful lip. All right, you want to kiss that. So this is one very important space that I've spoken about. All right, and after the I think we've covered most of the spaces. Therefore, and the next space obviously is the one which is peritonsillar space, and the peritonsillar space is usually discussed along with tonsils. So I think I've covered the two the very, very important spaces that is present along with the pharynx and various parts of the pharynx, and also the musculature of the pharynx. Not much importance is given to the concept, to the origin of the muscles and the insertion of the muscles. But I guess that is very common, and that's very fine. All right, the contents of the muscle, the contents of each of these contents of the pharynxes we've spoken about the contents. There are some things that I haven't spoken about because I thought that's very basic. Like the content of the nasopharynx is also something like a eustachian tube, which I do not really need to talk about, I guess. I do not also want to talk about how uh, there are some things that might be that we have to look into the contents, obviously, like the pyriform fossa and stuff like that. We need to talk about that. But other than that, I do not really want to talk about a lot of things, and I wanted to keep the video short, so this is it.